My name is Dr. Jaime Ruszkowski. I am a local internist and I'm here to talk about food allergies. I also am a mom of a food allergic child for the past 12 years, and I basically developed this talk so that we can talk medically about food allergies from the perspective of an internist, but please remember I am not an allergist or a pediatrician. Well, welcome everyone. I think there's a couple new people here who haven't seen this talk before. The crux of the issue is learning that we're dealing with a chronic disease and not just with food preferences. So the scope of the problem. So food allergy is a chronic medical disease. It affects 1 in 10 Americans. That is 33 million Americans with life-threatening food allergies. So the problem is that in the ERs of seconds, someone is in the ER with a food allergy reaction. Of those 33 million, 6 million of those are children. So in our classrooms locally, you can expect a couple children in each class that will have a life-threatening food allergy. So what is a food allergy? One of the bigger questions. It is an abnormal immunologic response, and it's usually following an ingestion, but it does not have to be of food. Usually it is the protein component of food that the body reacts to. And IgE is the specific immunoglobulin in the body that produces this response. The reason you want to remember this is IgE responses can result in anaphylaxis. So by definition, when we're talking about food allergy, it is possible to have anaphylaxis from that IgE, and we're going to go through what that is. And I'm sure many people have heard about the top food allergies in the United States. These foods here account for 90% of reactions that are documented, although there's something around 180 that have been noted by the FDA. So these are the top 8: milk, dairy, peanuts, egg, soy, fish, and crustacean shellfish are much more common than mollusks. So those are the crab, lobster, and shrimp. And just recently, in 2023, one of the bills that my daughter and I advocated for was the FASTER Act, which labeled sesame as the United States' 9th food allergen. So these are the top 9 things to look for that may result in a reaction, but you always want to remember that any nut other than peanut is the best way to think of it. Even though the FDA labels coconut, it really is not. Allergy Awareness Month in the United States, and the CDC has reported increased prevalence of food allergies by over 50% since 1997 to 2011. I don't have any more updated data, but it is huge. It is something that you may not recall as a child that is now happening to everyone that you know, essentially. Pretty much everyone is touched at this point by someone with a food allergy. Former recommendations before this dramatic rise was to delay the introduction of allergens to infants, but then the new recommendations in 2017 really talked about early introduction of food allergens. So this was based on a pivotal study called the LEAP study, Learning Early About Peanut Allergy. That was in 2015, and they really extrapolated their data to all the food allergens, although they were looking at peanuts. And they were looking specifically at infants consuming peanuts early, if that would decrease the likelihood of them developing an allergy. And it did. They also noticed that high-risk babies, so children, families that have food allergies, can actually be tested at a very young age, and foods could be introduced safely if they did not have a positive test. LEAP went on to have another study, a follow-up called LEAP On, which also showed that decreased peanut allergy risk among children who were able to consistently eat that peanut allergy. So not just when they were infants, but into childhood as well. It was one of the best ways to avoid developing an allergy. So how are food allergies diagnosed? And this is a topic of, I guess, confusion, really, because there are different ways to test. But the most important thing I want you to remember is that it's really a clinical reaction. So it is not by blood work. It is not by skin testing. It is every time I drink milk, I get hives. That is clinically relevant to and suspicious of a food allergy. The testing that your allergist can do is going to confirm that that, in fact, is the allergy. And the 2 main ways to do that are by skin testing, which is scratch testing, and that can only be done by an allergist. That is not done by your primary care or a pediatrician. And there are also blood panels, but many people don't recognize that the blood panels, really that's showing what you're sensitized to. It's not saying you're allergic So it's looking at your IgE levels to specific foods, but it doesn't mean that you can't have that food safely. It means at some point you were sensitized. At some point your body wanted to react to it. But that does not mean that you should avoid that food. So I really caution people, there's a lot of tests that are actually, not even FDA approved that are available for purchase over the internet, that you can take to your doctor and get tested for hundreds of foods. And that's really not the way you want to go about it. If you're worried you have a food allergy, you really should see a board-certified allergist. And we're going to review the symptoms of food allergies in detail, but hives are one of the more cardinal symptoms of food allergies. So this is what the data was based on in these studies, through the studies that were actually done. I don't know where they got these specific numbers from, but this is exactly my point actually, because food allergies are not easy to diagnose. People think they have allergies, they don't know. They may be talking about blood work they have had done. How it's being coded at the emergency room visit is how this data is being reported. So also, many people, the majority of people, don't end up going to a doctor or don't end up ever having that data captured. So we really don't know, and that is not an accurate number overall. But what we do know is if you think back to your childhood and who you grew up with, right, it was not an issue that there were food allergies at that time. So the prevalence has definitely increased. Certainly can be in other in educated populations, particularly, of course. But and I don't know enough to say, like I said, I'm not an allergist, so I don't want to misspeak. But I will tell you that the crux of the problem is that food allergies are hard to diagnose. The guidelines are changing when to introduce food to your children. The etiology, why is this happening? We don't know. Food intolerances, that's a very different diagnosis than an actual IgE-mediated reaction that can result in anaphylaxis. The reactions themselves are unpredictable. So it's hard to know that maybe I have hives every time, but maybe one time I don't have hives and I have a cough. So it's hard to really know for sure. So there's a real spectrum that these reactions can be occurring. And not only that, but variables affect the reaction. So if you're sick, if you have a fever, if you're a woman and you're menstruating, if you are eating food on an empty stomach, if you have a larger volume of the food that is raw, it's not cooked. There are many different things that can affect the actual protein and how your body sees it and responds to it. So these are some of the most common reasons that you may have a difference in reaction. One of the most important I find is actually the age of the patient. So in kids, you're going to see more commonly cutaneous signs or skin signs, hives, eczema. But adults, a lot of times that is not actually the case, and it's important to remember that you can still get anaphylaxis, you can still have reactions without noticing signs on your skin. So food allergies can change over a lifetime, and so the reaction you have may change. You may not be allergic to something and develop it in adulthood. And some food allergies are more common to outgrow, and those particularly for children are going to be milk, egg, soy, and wheat. It is much less common to outgrow the peanut, tree-nut, fish, and shellfish allergies. But this is all variable as well, and we don't understand why some are outgrown and some are not. So the potential for life-threatening reaction, so it's really inherent to the diagnosis of an IgE-mediated food allergy. So as we talked about, the severity is multifactorial, it's variable, and you really cannot accurately predict what is going to happen. And that's important to remember because many people like to classify their food allergy as either mild, moderate, or severe. And that's really not what we're talking about. We're talking about you either have a food allergy to milk or you don't. And that's really the way to think about it, because if you have the allergy, you are at risk for a severe reaction. You should be, by definition, carrying an EpiPen. The level of IgE on blood work is not predictive of reaction. So that's, again, that whole sensitization, why some people have high IgEs, why some patients do not. We don't fully understand that. So you can't rely on the testing for that. And likewise, when the allergists test your skin, they actually do little scratch tests with milk. I'm just going to stick with milk, apparently, for today's purposes, which my daughter is. No, my daughter has been allergic to milk since she was an infant. So when they scratch test, you can get huge wheals or hives from the milk. But that does not necessarily correspond with your risk of severity. And that's part of what is so tricky about this diagnosis. So IgE reaction, so what actually defines a serious reaction is that it's rapid and can result in death. And we believe that is a systemic mediator release from sensitized mast cells and basophils. So those are certain types of cells in your immune system that fight different threats to the body, and they're recognizing the food as a threat to your body. Typically, for a food allergy, for IgE, you're looking at a reaction that occurs within 2 hours, usually 20 minutes to 2 hours. It can be biphasic, meaning you can have a reaction, it calms down, and then 6 to 12 hours later, you can have another reaction. And that's really where a lot of the guidelines came from, that if you have anaphylaxis, you should be dialing 911 and having someone observe you in case you were to go into anaphylaxis again. And the definition of anaphylaxis itself is not solely one thing. So we need to be aware of the different combination of mild symptoms and also the severe symptoms that are telltale signs. I have found in all my years of research that this is the most helpful. This is from FPIES, which is Food Allergy Research and Education. I actually have, there's a lovely poster back when my daughter was in preschool. I used to give them to the schools. They used to hang them in the rooms. They hung them in e-school, and these are very helpful for babysitters that come to my home, etc. Because when it happens, it's hard to know if you really should be concerned or not. And a lot of these symptoms you cannot accurately diagnose, without instruments, without a stethoscope, without checking blood pressure. So I'm going to go through each of them, and you can stop me if you have any questions.
What can you get a copy of this?
You can, I believe Shannon may have a way to send out the slides. So severe symptoms are a little bit easier. If you see someone that all of a sudden is short of breath, and they have a food allergy, that one's pretty apparent. Wheezing, coughing. The most important thing to point out here is that there is a very high overlap between food allergies and asthma. So this is really where the trickiest is the patient who has asthma, because these are their asthma symptoms. And asthma and allergies, food allergies, can present in the same way. Notably, though, epinephrine treats both, and that was one of the oldest tried and true treatments for asthma is going to be epinephrine. So it is always okay to err on the side of food allergies if you do not know. For the heart, for patients pale, if they fainted, if they don't have a good pulse, if they're dizzy, that can be a sign of anaphylaxis. Throat, people may identify tightness, itchiness, you may see their tongue, their lips swell. You notice that quite easily, but sometimes you don't have that. Skin, hives. Couple hives are not as concerning, but when you're looking at someone who has full body hives that are progressing, and they're not getting better, that is very concerning for anaphylaxis. The gut one is hard as well. Are you having some kind of food reaction, some kind of bad food? Do you have a nervous stomach? Did you eat something that was spoiled? But repetitive vomiting or severe diarrhea with the right timing and the right clinical story can be a sign of anaphylaxis. The other category is hard, right? Feeling like something bad is about to happen. And that's not easy to measure. And that's a lot of what the comorbidities are with food allergies, is the sense of anxiety and fear, and the fact that you're not able to fully categorize what these symptoms are, and you're relying on the public to identify them as well for you and to give you treatment. So any one of these, you would be concerned about anaphylaxis. If you have more than one mild symptom, like just itchy nose, and I do not have the statistic on me, I wish I remembered this, but there is a statistic that a very large percentage of students that go into anaphylaxis at our schools were never diagnosed with food allergy. That's their first way of presenting. So that's why it's also good to think about this even in someone that you're not aware has a food allergy, particularly children. So anaphylaxis, because of all these reasons, is significantly under-recognized and under-treated. There may not be skin symptoms, there may not be clear consciousness. So early recognition and management is really what's essential to ensure a good outcome. So we spoke a little bit about some of the risk factors for severe reactions, and I will tell you the number one is going to be asthma. So the asthmatic patient who also has food allergies is at the highest risk for severe symptoms, or symptoms to be accounted to their asthma when it's actually lack or delayed administration of epinephrine is largely what is responsible or thought to be responsible for deaths. Either people don't have their epinephrine on them, they're delaying in administering it, they're denying some of these symptoms because it's hard to know. They feel something bad's going to happen, but there's no hives. They maybe have some alcohol, maybe the judgment's impaired, maybe the absorption is impaired of the food. So these are all things you want to think about, and you never want to rely on oral antihistamines but once the allergic anaphylactic cascade has started, they're not going to be able to stop it. So you should never take Benadryl and go to bed and hope that it goes away, for example, which is what many people. So approved treatments for food allergies. So up until 2020, it was really just strict avoidance of the allergen. It was the absolute only treatment, followed by, if you accidentally did have an exposure, to know your allergy action plan, identify symptoms, and identify whether or not you should be using epinephrine. And so yes, mild reactions to keep patients, especially young children, comfortable, you can consider antihistamines such as Benadryl, which is the most quick-acting, or diphenhydramine, which is the generic. For severe reaction, you really are looking at epinephrine, and what's important for this is really that epinephrine has a very, very short half-life. If you were to be in an emergency setting, you can give it through IV. You can give epinephrine every few minutes if we were in a code situation at the hospital. So part of my goal of this talk is to really empower people that epinephrine is, there's really no absolute contraindication to epinephrine, and that if you are ever with someone that is you believe to be suffering anaphylaxis, and you've given them their dose, and you do not notice they're better, it's been 3 minutes, the ambulance isn't there, give it again. And that is okay. You cannot. Epinephrine is not available at this time over the counter. So food allergies, another quote that we learned at our last Courage at Congress with there, food allergies are not just when you eat. Food allergies are all the time. And really because avoidance is the only treatment that was available until 2020, you really have to rely on being able to read labels to protect you from accidental ingestion. Using food safety apps, finding brands that are safe for you, that are reliable, knowing where your allergens hide. My daughter has a sesame allergy. I was not aware that the majority of chapsticks, lipsticks have sesame oil. So it's not just food. It's not just when you eat a meal. You want to be able to assess your cross-contact risk. So maybe you have a peanut allergy and not a walnut allergy, but can you get walnuts that are completely free of peanuts, not processed in the same facility, and eat those? And everyone's different, but these are all the things you need to be thinking about, and knowing how to remove possible food allergens. And this comes up a lot in our schools. Purell does not remove food allergies. So Purell definitely kills bacteria and viruses, but you need mechanical washing off of the food protein. So wiping with wipes is acceptable, preferably washing with soap and water is going to remove allergens. And so you really want to train children and people taking care of food allergic people to be washing their hands before and after. So this is the act that was designed to protect people for food allergies. The Food Allergen Labeling and Consumer Protection Act. It's old, 2004. So it's called FPIES, and there's a couple things to really realize about this. So this labeling only applies to FDA regulated, that means packaged foods that you buy at the grocery store in a package. Vitamins, medical foods, formulas, these are required to be labeled in this manner. They require that the top 9 allergens that we referred to before are labeled. So that, amazingly, does not include crustacean shellfish, which is crab, lobster, and shrimp. That is something to think about too. Even though these things are required to be labeled, they are the only things that are required to be labeled by law. They want you to list the allergen in plain English. They recommend to have a contain statement immediately at the bottom so that you know of those top 9 in bold and highlight what's present in that product. The issue of the labeling, really, a lot of that has to do with cross-contact, because even though it's required that you label what's in it, there's not necessarily the same procedure required to safely avoid cross-contact. And so cross-contact can be obvious that the peanut butter is mixed in the jelly, but it can also be at a microscopic level, and that can be enough if you have the right sensitized patient. So even if you can't see it, there may be enough allergen present to cause a reaction. So again, FPIES does not regulate the use of precautionary statements. Every statement here that you see is voluntary, based on the company. And they all mean the same. One isn't necessarily safer than the other. They're all voluntary statements. May contain, manufactured on the same line, in a shared facility, on the same equipment. This doesn't, it's not associated with anything in particular that's FDA labeled. This is just something the company is putting out there. And unfortunately, what you see is a lot of the bigger brands will just say all of them, just as like a blanket warning. We'll say all the 9 allergens, unfortunately. Other things outside of alpha, besides of the cross-contamination list, one of the things that is most important for me as a physician is prescription drugs and over-the-counter drugs. These are not required by U.S. law to be labeled for food allergens. So when I prescribe a patient a medication that has an allergy, I do not know what is in that drug. It's not required to be labeled. So particularly, it's the binders in the medicines over the counter, so like chewable Benadryl, chewable Aleve, tablets that are bigger and chewable have binders in them that may be foods, and people can be allergic to that. Likewise, lactose is one of the biggest binders in many of our inhalers used to treat asthma. Also in other medications that the allergic community uses, such as Singular. So there's actually an act on the table right now, I believe it's in the second year, called the Adina Act, and there's this lovely girl, Adina, who had anaphylaxis from a binder in a medication. And so we're trying to get that labeled as well. Other things on this list, cosmetics, shampoos, lipstick, kosher labeling is not regulated by FPIES. Alcohol, spirits, mixers, anything you buy in a restaurant, it's not packaged. They're not going to be obligated to tell you what's in it. Pet foods and supply supplements can come into play as well. So these are all things to think about, particularly when we think about cross-contamination. So the takeaway points really are that you need to be able to be comfortable reading packaged food labeling every single time you buy a food. Foods can change, the companies can change, and they don't need to notify anyone. My daughter has been using the Safe brand of yogurt her whole life, and just this year they started to say, may contain other true nuts. And if you're not reading that closely, it's the same thing I've bought her for a decade. And there's no kind of labeling or awareness that is required when companies change their recipe. Allergens can also hide as part of spice or natural flavoring. This was a big problem with the sesame. But now, anything else, so the other two that come up often are garlic and mustard. Those are two things that are also more common for reactions, and those can be listed just as spices in food. They don't have to be declared. So you want to familiarize yourself with your allergen, foods, products they're in, looking at the cross-contact risk, and really think about repackaging of items. I'm sure many of you have heard about the terrible story at Stu Leonard's where the young dancer died. And she was eating a cookie that was relabeled by Stu Leonard. So, it was sold by Stu Leonard's, and the company has stated that they did send an updated label to Stu Leonard's. But, excess packaging or times that is handled puts you more at risk for possible cross-contamination. So, you must really be prepared for an accidental exposure. And the way to do this is to develop an action plan with your physician. You need to know when you're going to use Benadryl, when you're going to use epinephrine. You need to think about, especially with a child, is it ingestion known? Do you suspect it? Can you identify, are you leaving your child with someone that can carefully identify what a mild reaction is, what a severe reaction is, and is it anaphylaxis? So anaphylaxis are those severe symptoms. So that is a term that we use for severe.
When you can't breathe.
That's one of them. And if you remember, we did this lovely diagram. So these are the symptoms of anaphylaxis. Any one of these symptoms, or more than one of these mild symptoms. And so this is very helpful for caretakers, people in schools, but also when you look at your allergy action plan with your physician, with your allergist, it goes through these symptoms and tells you, should you be injecting epinephrine, should you be observing, should you be calling 911, and those are all things you want to be developing with your allergist, specific for your allergies. And they may, be different based on, you can have 5 allergies and a different plan for each one. I mean, that is possible. And these are required by law at camps, at schools. So with someone with a food allergy, each child will have these forms. So reactions can occur outside of ingestion of food, and that's what's really one of the most challenging things, contact reactions. People, especially young children that are, touching things, touching peanut butter that's left on the seat, putting their hands all over their face and their friend's face and the mouth. So any of those mucous membranes, the eyes, the lips, if you get enough exposure to that area, you can get enough systemic absorption to result in anaphylaxis. This is very rare, but it's important to be aware that this is possible. Reactions from inhalations are actually the most uncommon. It's really specific aerosolization of food proteins that can result in irritation to the respiratory mucosa. And that's really going to be like when they do like seafood boils, steaming milk, being in a shop where someone's grinding the nuts right there. There's a large load of allergen in the air. So treatment for anaphylaxis. So number one is to eliminate the additional allergen exposure. So if someone's eating it, you need to remove it. If it's on their lips, you need to wipe it off. You want to inject epinephrine intramuscularly into the thigh. And after you inject, then you're going to call 911. You don't ever want to delay the administration of epinephrine to call 911. If possible, you can lay a person down just to help perfuse the brain and elevate their legs. You don't have to, but this is the preferred position to tolerate it. So I'm going to talk about there are two main ways to deliver automatic epinephrine in this country. One is the EpiPen, which is also, they have a generic Adrenaclick, and one is something called the AviQ. Both of these are automatic ways to administer epinephrine. And the really important things to remember about this is that they need to be maintained correctly because they are medications. You can't freeze them, you can't refrigerate them, you can't leave them out at the pool all day in direct sunlight. Generally, they need to be at room temperature, so that's going to be 60 to 77 degrees. Excursions, although not fully defined, for how long it's permitted, are allowed between 59 and 86 degrees. So if you're going out in the cold, you can't leave your EpiPen out, in the freezing cold for hours while you do something. Unfortunately, they can't guarantee that the epinephrine is still going to be active. So they do recommend that you check from time to time and make sure that it's not discolored, cloudy, or that you see any particles in the epinephrine. So for the AviQ, it's a little bit easier to see. Usually you can see right in between here. But there's only these little, and this one talks a lot, but there's only these little areas that actually show you where the epinephrine is in there, and you're supposed to be looking at those regularly. You always want to carry 2 of them, so they are prescribed as a pack of 2, and that is because there may be a device malfunction, or, like I said, it may be that the reaction is so severe that you need another one. Maybe it didn't fully get into the muscle. That's always possible as well. The other caution is that there are labeling of expiration dates, and this has been debated. They've been extended in the era of COVID. So this may change, but in general, you're going to get something that lasts about a year from the pharmacy, and you do want to check that before you take it home, and you want to be aware of when it's going to expire. As far as the administration of Epi, it's actually super easy. That's the easiest part about it. So they happen very quickly. This AviQ, which is the talking one, is 3 seconds to inject, and the EpiPen is 3 seconds, and the AviQ is 2 seconds. So you want it in your mid-outer thigh. So I'm going to show you how to use both of these. If you need to, you can inject it through clothing if you want, in case the clothing is a barrier, like there's a seam or a pocket. But if you need to, you can. There are these trainers, which typically do come when you purchase epinephrine. I do have a couple more back there as well. But I'm going to show you how to use both of these. It's very easy. So this is the EpiPen, and the way that you want to think about this is blue to the sky and orange to the thigh. And you just count to 3, and that's it. It's very easy. So you can pass that around if you want to look at it. The other one, the EpiPen that is in the AviQ, is very talkative and will walk you through the entire process.
Or drug and is for training purposes only. Do not use this trainer during an allergic emergency. If you are ready to use full red safety guard, please blast them against outer thigh. 2, 1. Training complete.
Does the real one talk to you too?
Yes.
Trainer may be reused for training purposes.
So this one's really, really nice because, when this happens, people are nervous. They're not sure, and so it's nice to have that, especially for children or your friends, because you really want to be able to tell your friends and family. They need to be able to understand your situation with allergies and how to keep you safe. So epinephrine first. first epinephrine fast is our mantra. And that and I hopefully by now I've convinced you that the benefits of epinephrine treatment far outweigh any risks of unnecessary dosing, and that delays in instituting epinephrine are really going to be what's associated with risk of death and morbidity. And there are no absolute contraindications to epinephrine use in anaphylaxis. So barriers to epinephrine use outside of the whole list of safety and storage recommendations I gave you, is a needle. And people don't like administering needles, particularly children. People feel that they're uncomfortable administering a needle to another person particularly. It's hard to keep at the right temperature. They cost a lot of money, hundreds of dollars for EpiPens. Many people use it once, don't realize they can give another dose. They call 911 and wait for 911 to administer the epinephrine. Or they incorrectly believe their hives or whatever symptoms, itchiness of the mouth is getting better with Benadryl, and it is not enough. So the use of antihistamines is the most commonly reported reason for not using epinephrine, and may place a patient at significantly increased risk of progression to a life-threatening reaction.
I have a question, just for institutions like a library, that it seems like it would make sense for, schools and libraries and gyms or, places to have EpiPens available. Do you know of any services or grants that can allow for that, or, to make it a little bit more affordable? Because 1 year for hundreds of dollars is a huge barrier.
Yes. And it really is very interesting. So as you may have noticed, the AEDs or automated defibrillators are everywhere. Those are thousands of dollars and last for 4 to 5 years. And those are more cumbersome to use than what we're comparing it to right here. So there has been a big push for that. I've actually been involved in legislation at the state level as well. And unfortunately, this is all state-based. So Connecticut does have a stock Epi law that came out, I want to say within the last 5 years. So restaurants are able to order epinephrine. Physicians' offices, schools, daycares, they're able to have one. I don't know exactly what that process looks like, but that is what the law changed a few years ago. And that's really the goal, is to train enough people and to have enough people aware that they feel empowered enough to just administer it. And these are the slides specifically going through how to administer, but we already did that little training part, so we'll just skip through this. There are multiple studies going on now for different delivery mechanisms. The nasal one is the biggest one that they're looking at. Unfortunately, this neffy was just rejected by the FDA in the fall, but there are multiple ones out there now seeking approval to do as a nasal spray. That is unclear why it was rejected, because the studies, from my understanding, you are not allowing people to go into anaphylaxis. They're really administering epi and then being able to look at your blood at the, what's your heart rate, what's the level of the epinephrine. So it was something that they weren't convinced that the levels were high enough, something to that effect.
But they use these for kids in the ER. They already, multiple drugs intranasally.
Oh, of course, right.
So I don't understand why.
I don't think anyone understands, but other than the fact that there's a lot of a lot of stake in the companies that hold epinephrine.
Yeah.
I mean, that's largely what I think this boils down to, unfortunately. They basically just said they needed more data to prove it. And the automated epinephrine injectors have not changed. Have not changed since the 80s outside of the Allergy. So really, it's amazing. But these are coming to a forefront, and there are more than one right now that they're looking at. So we spent most of this talk talking about treatments that are approved until 2020. So what happened after 2020? So other than avoidance and epinephrine, 2 big things happened. One was just a few months ago with the approval of Xolair for multiple food allergies. The other was Palforzia. So Palforzia was approved in 2020. It is the only approved oral immunotherapy in this country. It is only for peanut allergy. It is only prescribed by allergists, and it is prescribed in escalating doses that are recommended to be maintained over a lifetime. Xolair is an injectable medication that gives a little bit more safety to people that have multiple food allergies. So we're going to focus a little bit more on that. So this is the Palforzia, which is the peanut allergen powder. So again, it's a prescription through your pharmacy. It's FDA regulated. You still are going to avoid peanuts, but you are going to continue this medication. And it's approved for ages 4 to 17 for initiation, but you can continue it through adulthood. Outside of that, Xolair was just approved this past February. So Xolair's been around for a long time for asthma. And the way to think of this is anti-IgE. So IgE being the biggest player in anaphylaxis and food allergies, this monoclonal antibody is going to target the IgE, reduce the circulating levels, and basically make it so that the reaction is unable to be as severe. So to use this medication, you have to have multiple food allergies to really make it worth the risk, right? Because this is a medication that's injectable. You need to do it every few weeks. It has to be kept at certain temperatures. And it essentially is lifelong until any other treatments are developed. So the experimental food allergy treatments are probably things you've heard of. A lot of people, particularly in this area, in more wealthy communities, have done these. So these are different types of oral immunotherapy where people are following certain specific protocols to ingest allergens, whether they do one or more at a time. So their goal is really trying to alter the allergic response to desensitize the patient and allow them to tolerate the food. This can be done under the tongue, it can be done with a little skin patch, it could be done just a little blip under the skin subcutaneously or oral. So that's one big one that you may have heard, SoCal, other places that people are flying across the country for to do this type of treatment. And then the ART, the allergy release technique, is a more holistic approach, which is also available around here in New York City. But neither of these at this time are FDA approved. Studies are ongoing with this type of immunotherapy, particularly at Mount Sinai and other big centers for research. But at this time, it's not recommended to look into this other than an FDA-regulated trial. So I'm going to touch upon some other reactions that can occur, mainly ones that are outside of the IgE. There are two notable IgE reactions in here, which, one is oral allergy syndrome, which is very common this time of year. It's basically when plant pollen looks to the body as a food does, and your body reacts to that. And then there's also a phenomenon called food-dependent exercise-induced anaphylaxis. So exercise is something that does lower the threshold for food allergies, and particularly consuming certain foods temporarily related to exercise can trigger a reaction. Other things we're going to touch upon: celiac or gluten intolerance, lactose intolerance, FPIES, alpha-gal, which is a tick-borne illness too that has unfortunately become more prevalent here, contact urticaria or hives induced by food, and eosinophilic esophagitis. So I'm going to touch on these briefly, but you can stop me if you want to hear more. The oral allergy syndrome is very interesting because it is a local IgE reaction. So local tingling, as you're talking about, to raw fruits, vegetables, and it's really the body mistaking the structure of the food with an environmental allergy they have. So if you're allergic to birch, if you eat apples, you may notice that. And the trick is either baking or skinning the fruit, and usually you're able to tolerate them. It's incredibly rare that this would result in systemic anaphylaxis, but it is IgE mediated. And treating seasonal allergies with allergy shots avoids this phenomenon too, because if you treat allergies, you're avoiding the body's sensitized response to it. Exercise anaphylaxis, so 30% of cases are triggered by food. Your body is in a different state when you are exercising, and this actually is most common in adolescents. So kids that are doing sports and have food allergies, you really want to be aware of this. You want your coaches to be aware of this, and more foods, particularly nuts, are associated with this as well. It's a gluten-sensitive enteropathy, so it is the lining of your intestines that is bothered by the allergen. So it's the small intestines that become sensitized to gluten and related proteins. And this is a non-IgE mediated reaction. So thank goodness it does not result in death, but it can be really challenging to live with: diarrhea, malabsorption, weight loss, anemia. Luckily these days we're much quicker at identifying it, treating it, and there are a lot more options for a gluten-free diet. Milk intolerance, not the same as an IgE mediated milk reaction. So this is really lactose intolerance, and that means that you don't have enough, your body, of the enzyme lactase, so that you are not unable to fully digest the lactose that is in milk product. And that is something that happens in infants particularly, but again, it happens GI bug that's very common. So this happens often, but this is not IgE mediated, and really the treatment is just to avoid ingesting those foods or buy the lactate ones over the counter, which have less lactose in them, or even tabs that those are all available over the counter that have the enzyme that can help you absorb the milk product. FPIES is one that is actually not as well known. It is more of a GI mediated reaction, and it is a bit delayed. So this is a food protein induced enterocolitis, and is more common in young infants. It usually is 1 to 4 hours after ingesting the food, and it's really typically extreme diarrhea and vomiting. And that can be very confusing in the beginning with anaphylaxis, and a lot of that is going to be the time course of when you have it. So food triggers, this is a common one for crustacean shellfish, but milk, you may hear infants that have the blood in their stool from the milk, the cow's protein allergy, and that's what they're referring to here. So adults can still have it, but it is much more common in children. Alpha-Gal syndrome's been all over the news. It will be again as we head into the summer. We are somewhere around 500,000 Americans that are affected by this, and it's really wild. It's an inability of people to tolerate the alpha-Gal sugar, not a protein like a normal allergy, once they've been bitten by a specific tick. They become allergic to this sugar, and unfortunately this sugar is in all sorts of products that we are around, leathers, cosmetics, soap, toothpaste, and the reactions are variable. Hours after exposure, they can be it could be the next day. So this is a very tricky one that is new and emerging. Contact urticaria is what we think of as the cutaneous or skin manifestation of allergies, and this can happen in the extremely allergic person or child by just rubbing and getting that through your skin, particularly if your skin is broken, rubbing any kind of food allergen there. So the direct contact of food itself, as opposed to ingestion, can result in significant hives. And hives are just itchy red bumps, and they resolve within hours to days. So these are different examples of what they may look like. Eosinophilic esophagitis, this is dysfunction by the eosinophils, which are these cute little blood vessels with the 2 little nuclei there, and they can take over in your esophagus, and they can react to foods. And that's actually one of the biggest concerns with the oral immunotherapy, is that there's higher incidence of eosinophilic esophagitis. We don't really know if people are tolerating or desensitized to food or not, and sometimes you just get a lot of inflammation in the esophagus from eating the food, even though the person does not appear to be having any others. But there's a high association between this, food allergies, environmental allergies, and asthma.
Can I just ask a question about the atopic dermatitis compared to the anaphylactic reaction with rash? So are they different, or are they the same?
They're the same, and that's the hardest part for children. So, if you're not observing your child all the time, and your child's 2, and you see them with hives, how are you to know if they just got some peanut butter on them or if they ate it? And you don't. And that's the biggest problem with contact urticaria. So a lot of the times with the contact, you have to, families will identify, and you really need their help with the allergy action plan. So my child was highly contact reactive. So they knew that, and they knew that if it was a tiny little area, that they could first wash it with soap and water, just watch and see. But if it spreads, then you really need to think about just giving the EpiPen. So contact urticaria is from the actual contact versus anaphylaxis, which is going to be widespread. So I am by no means suggesting that you would give epinephrine for a contact area. But what I'm saying is, it is possible to have a lot of overlap in this. And so, you really do need to be aware that this can happen. And what happens is more people that have eczema that are atopic, they're more likely to have this phenomenon. And, their parents or someone, you're going to have to rely on them to tell you that this happens to their child. But this is not an anaphylaxis if it's one specific area that is not sprayed. So there are a lot of things to think about as far as rights for American children with food allergies. The Americans with Disabilities Act in 2008 protects those with food allergies against discrimination. And it means that they must be accommodated in public schools. So if you have an allergy, You can consider if a 504 plan is right for you, which is a formal plan by the school to, accommodate your child with whatever their allergens are. The Office for Civil Rights on a national level also just released another statement addressing guidance on food allergies, protection, and 504s for the food allergic children. Other things to think about if your child goes to camp, particularly, EpiPens are required by Connecticut law to be kept in unlocked, easily identified places that anyone would be able to grab quickly. The thought is that within 2 minutes of anaphylaxis is when you really have the highest efficacy of administering the epinephrine. So you really want to be able to get that EpiPen in right away. So easily accessible, identifiable with the Children's Action Plan. A lot of places use their picture right there as well. Bus safety, this again is at a local level. So this was done in Connecticut about 6-7 years ago. All Connecticut school bus drivers are trained to identify anaphylaxis and administer epinephrine. So all children are now allowed to self-carry epinephrine. So even your 5-year-old, your 6-year-old, your kindergartner, if the parent and the allergist have felt that is appropriate, that is now an option. Self-carry is now allowed even if the child is too young to self-administer. And that is solely for the bus drivers, for older people, there's an aide on the bus, for anyone giving them the power to use epinephrine if needed.
And just a reminder for us that there is no negative side effects to taking an EpiPen if it's not anaphylaxis, but it looks like it's anaphylaxis and
Yes, it's okay. So epinephrine is your body's normal adrenaline, right?
Yeah.
So it's your fight or flight response. So when you get nervous and your heart rate goes up and your body's ready to fight, that's what epinephrine does. So your body goes throughout this, at different times of the day of your life normally.
Yep.
So all we're doing is giving that to you right now to basically treat anaphylaxis. So, the hard and fast, if you really were to think about people that you'd be worried about giving it to, are going to be people that have severe cardiac problems, people with severe arrhythmias, people that are elderly on 20 medications, and those are all things that sure, we need to think about, but in general, there's no contraindication because that epinephrine, it only lasts for minutes.
I see.
And we use epinephrine as part of codes, as part of reviving, as part of resuscitation. So it is very safe. It's basically just going to cause a very big fight or flight response for a couple minutes. And it may not be pleasant if you didn't need it, but it is okay. So these are just some of where I got these guidelines. The guidelines from there's a diagnosis and management of food allergy in the United States report in 2010. FAIR, FACT, and FASI are 3 of the most, I suppose, researched, well-known groups that advocate for allergies and do a lot of fundraising. And if you have any specific questions, you can contact me. That's my daughter.